We'll go live.
Okay. Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. My name is Ahmed Al-Saeed. I'm a consultant hematologist and deputy chairman of Princess Noor Oncology Center at King Abdulaziz Medical City, Western Region, Jeddah. I would like to welcome you, all of you, today for the this SSBMT webinar series, which will be with the title "How I Treat Myelofibrosis," with focus on stem cell transplantation. I would like to thank SSBMT for organizing such webinar series. I would like also to thank the sponsor for the whole series, and especially for the two-day meeting, which is sponsored kindly by Novartis Oncology. Today, we have an eminent and international figure speaker on myeloproliferative neoplasm. Today, we have Dr. Francisco Pasamonti, who is a consultant and professor of hematology and head of division of hematology at the University of Insopria, Varese, Italy. Dr. Pasamonti is well known in involvement in clinical trials in hematological malignancies, and especially in area of myeloproliferative neoplasm, especially in Philadelphia chromosome negative polycythemia vera, essential thrombocythemia, and myelofibrosis. Prof. Pasamonti participated as a panelist in the definition of diagnostic criteria, response to treatment, and guidelines for treatment decision in multiple of the MPNs. And he authored more than 300 papers, and he is also a member of many of the international societies. So our session today will be divided into three parts. Part one, Prof. Pasamonti will speak about how I treat myelofibrosis, focusing more on stem cell transplant. And then briefly, I will present some cases on of myelofibrosis. And at the end, we will open the floor for question and answer. I wish all of you a good meeting. And Prof. Pasamonti, floor is yours.
Dear Hamed, thank you for the really nice introduction. And of course, it would be better to stay all together instead of stay with this distance. But however, this is the time of this terrible disease and infection. So this is the only possibility we have now to discuss it, to stay together in a different way. So my task force today is to discuss about my personal approach to patients with myelofibrosis with a special focus on stem cell transplantation. And the first point when I see a patient with myelofibrosis is to study the prediction of survival. This is, of course, very important for the patient, but it is quite important for us as doctors to plan the treatment. So I use the IPSS at the time of diagnosis or the DIPSS when I meet a patient during the follow-up. And I think that we don't know to present it's not necessary to present the IPS or DIPS models, as these are very well known. As an alternative to IPSS and DIPSS model, I want to quote the MIPS-70. The MIPS-70 is an integrated clinical and molecular model that took under consideration some hematological parameters, bone marrow fibrosis, the absence of CALR type 1 or type 1-like, the high molecular risk profile that included mutations such as SXL1, IDH1, and IDH2, SRSF1, and EZH2, and to have more than 2 high molecular risk mutations. And on the basis of this, we can stratify 3 different groups of patients. And when we have a patient with post-PV or post-ET myelofibrosis, namely secondary myelofibrosis, I use the MySEC-PM model that was developed only on patients with post-PV and post-ET myelofibrosis. So it is the only one we have today for this category of patient. And the MySEC-PM takes into consideration some clinical parameter and the CALR unmutated genotype as a negative predictor of survival. And on the basis of this parameter, we can stratify patients into 4 different categories. There is a website where you can easily assess the risk of your patients. And so in Italy, we continue to use the ELN stratification, the ELN guidelines for decision on treatment. And when we developed these guidelines, we decided to start from the problem. So which is the problem of the patient? The problem is anemia and the problem is splenomegaly. And sometimes you have both problems in the same patient. So which is the treatment for anemia we suggested? Corticosteroids, androgen, erythropoietin stimulating agents, or IMiDs. Of course, we know that these are not so effective. We can have a response in terms of anemia improvement, 20–40% of the cases. And we know that this efficacy is a short term. So in general, after 4–6 months of therapy, every patient loses responses. But if we have the deletion 5q in a patient with myelofibrosis, of course, this is 2–3% of patients with PMF, no more. I have in my practice 3–4 patients, no more than this. In these cases, it's very nice to use lenalidomide, because lenalidomide is very effective in this patient. So it is able to reduce 5q minus, to reduce JAK2 or CALR mutation. This is my personal experience, and control the hemoglobin level for a long time. Then the second problem is splenomegaly. And in Italy, in Europe, we have approved only ruxolitinib, but the FDA approved recently fedratinib. So the indication of fedratinib and ruxolitinib are more or less the same. And if we look at the indication we provided in 2018, we say that ruxo is indicated for intermediate 2 and high risk patient, and for an intermediate 1 with symptomatology as splenomegaly, or as in intermediate 1 without symptomatic splenomegaly after the failure of hydroxyurea. But today we have experienced that ruxo is safe and effective in intermediate 1 patients. So my personal practice is that I use for splenomegaly ruxolitinib intermediate 1, intermediate 2, and high risk patient. We will be back to allogeneic cell transplant further in my presentation. So which is the new possibility we will have in the future for treating anemia in myelofibrosis? We have to consider luspatercept. Luspatercept has been developed in a phase 2 study, and very soon we'll start the independent trial that is a phase 3 randomized trial. These are the results that we presented at the last ASH meeting. And this is a cohort of patients who receive red blood cell transfusion, so those who are red blood cell transfusion dependent. And you have to see here, we have 2 different cohorts. Cohort 2, that included patients who did not receive ruxolitinib, a cohort 3B, that included patients who received ruxolitinib. And here you can see that this is the cohort of patients who became red blood cell transfusion independent for more than 12 weeks during the entire treatment duration. And we can obtain red blood cell transfusion independence in 36% of the patients receiving ruxo, and in 19% of the patients not receiving ruxo. And here you can see the rate of patients who obtain more than 50% reduction in the transfusion burden. And this accounts for 36% of the patients on ruxo and 37% of the patients not receiving ruxo. So luspatercept seems to be able to improve anemia in patients who receive ruxolitinib. So this is a good point for the future. What about ruxolitinib? Ruxolitinib is the standard treatment for myelofibrosis. We know ruxolitinib exactly. We started using it many years ago. And so we can say today that 1 out of 2 patients achieve spleen volume response at any time. And the probability to maintain the spleen volume reduction was 51% at 3 years, and 48% at 5 years. So the efficacy is long-lasting. The problem we can have with ruxo are anemia, thrombocytopenia, and infections. And we know this. We have the information to treat this problem. What is important to know is that the baseline anemia does not impact on response in terms of spleen reduction. And the development of anemia we can see frequently with ruxolitinib does not affect survival. And again, I think this is a recent paper, interesting. And this is a sort of study of factors predicting higher spleen response. And the data come from the JUMP trial. We can see here very clearly that patients with intermediate 1 and low disease respond better. Patients who use ruxolitinib as first-line therapy respond quite better. And those who are treated with 20 milligrams per day of ruxolitinib at week 12 respond better. So, which is the message? I think that the message is that we can start ruxo in intermediate 1 and low risk patients if symptomatic. We have to start to use ruxo firstly, and we have to use the higher dose we can use. So, for instance, don't start with ruxolitinib at a lower dose just to avoid the need of red blood transfusion, because the higher the dose, the higher the reduction of the spleen, the better will be survival. And this is the response we obtained the JUMP. You can see here, for instance, that those patients who started at a lower dose increased dose over time. Those who start with a higher dose reduce the dose over time. And this is the median of the doses of the patient, that is around 20 milligrams per day. And here you can see the best percentage change from baseline in palpable spleen length at any time during the follow-up. And you can see that the median change from baseline is less 72%, so a huge reduction of the spleen. And again here, you can see responses, so more than 25% or more than 50% in the whole cohort, the blue column, and in patients with a low platelet count. And we can see that 80% of the patient, consider the whole cohort of patients with myelofibrosis in the JUMP, obtain a reduction of the spleen more than 25%, and 66% of the patient obtain a response more than 50% of the spleen volume. If we consider a patient with a platelet count between 50 to 100,000, the overall response rate was 64%, and 29% of the patient reduced the spleen more than 50%. So this is a nice reduction of the spleen. But if you ask me which is my view for the future, I think that ruxolitinib is okay, but the future treatment for myelofibrosis will be the combination. I just quote to you this very nice paper we presented at the last ASH meeting. This is a combination of a BET inhibitor plus ruxolitinib. The BET inhibitor name is GPI 610. And this is a study, this is the arm 3 of the MANIFEST study that included patient naive of JAK inhibitor with myelofibrosis intermediate 2 or high risk. You can see here the spleen response. 67% of the patient obtain a spleen volume reduction of 35% at week 24. Excellent. Double the response we obtain in the cohort 1 and cohort 2 for ruxo. And the second point is that you have a decline of hemoglobin level that very fastly has been restored. So it seems to obtain a good response on the spleen, leaving unaffected hemoglobin level. But we have the second unmet need. The first unmet need is anemia, but we will have probably luspatercept. The second unmet need is ruxo discontinuation. We can discontinue ruxolitinib for many reasons, from progression to splenomegaly increase, some cases of AML, and so on. And this is the possibility. This is a study done in Florida at the Tampa University, and this is survival obtained after ruxo discontinuation. The red line, the green line represents the patient who receives stem cell transplant. I think that, in my opinion, this is really optimistic, because in this difficult situation, so the ruxo discontinuation, the ruxo failure, obtain 80% survival in those who receive stem cell transplant is very optimistic. However, these are the data. The second curve represents those who receive salvage therapy, mainly clinical trials. And the blue line represents those who receive no treatment or observation, so very bad survival. So, which are the opportunity we have for second line? One is, for instance, fedratinib. Fedratinib is approved by FDA 1 year ago. It is effective. And we very recently reanalyzed the Jakarta 2 study. That was a study including patients who failed ruxolitinib. And we reanalyzed the patient on the basis of this definition, that is very stringent definition of ruxolitinib failure, relapse, refractory, intolerance. And on the basis of this criteria, we obtained a 30% reduction in the spleen volume. And you can see here that grade 3/4 anemia is present, but not so high as, for instance, with ruxolitinib. And fedratinib is very effective. You can see here the reduction of the spleen on the basis of the time. This is end of treatment 1, end of treatment cycle 2. And the end of treatment cycle 2, we have a very fast reduction of the spleen, so very fast. That's good. However, we have also other possibility, okay? Fedratinib is a JAK inhibitor, but probably again, the winner will be the combination. And this is an example. Navitoclax is a well-known BCL-xL inhibitor. And this is a study we did with Navitoclax on the top of ruxolitinib in patients who failed ruxolitinib. And it is clear here that this Navitoclax plus ruxo is able to overcome ruxo resistance. And you can see here responses. 27% of the patient achieved spleen volume response more than 35%. The total symptom score reduced in many patients. We have half of the patient who reduced the variant allele frequency of JAK2 or CALR more than 10%. It's not a huge number, of course, but this is a reduction at week 24. So this is of interest. And again, there is also a reduction in the bone marrow fibrosis. So this will be probably a nice cooperation. So BCL-xL inhibition plus JAK2 inhibition. And now there is also a phase 3 study, randomized patient to receive ruxo or ruxo plus navitoclax. You know that many studies are ongoing also for first-line therapy. We have, for instance, MDM2 inhibitor plus ruxo versus rux, navitoclax plus ruxo versus rux, PI3K inhibitors plus ruxo versus rux, selinexor versus rux, and so on. Now we have to decide about stem cell transplant. And this is not an easy decision. And in my practice, this is my mental stepwise. First, to select patients who might be candidates for stem cell transplant. And who are these patients? Patients with less than 70 years. If they have primary myelofibrosis, I select those patients DIPSS intermediate 2 or high, or mid-70 high risk. If the patient has a post-PV or post-ET myelofibrosis, I select those patients belonging to the median 2 and high risk according to the MySEC-PM. Why this? Because these are patients with an expectation of life on the basis of the disease course less than 5 years. The second step in my mind is to select those patients who might benefit from stem cell transplant. And for doing this, I use the recently developed MTSS. The MTSS model is a model developed by the group of Nicholas Kruger that takes into account age, platelet count, the number of leukocytes, the performance status, the genotype, non-CALR, non-MPL, the ASXL1 mutation, and the donor. And on the basis of this, the study generates 4 different risk categories with different survival ranging from 90% at 5 years to 34% in the very high-risk patient, and with an opposite risk of transplant-related mortality that is 10% in low-risk patients, becoming 57% in very high-risk patients. So the first issue, how old is too old? For instance, this is a picture of the number of patients with age 70 or older who received stem cell transplant in US from 2000 to 2013. The blue line here represents patients with MDS or MPN, mainly MPN. You can see that in the last years, the number of patients over 70 who receive stem cell transplant is increasing. So this means that focusing on chronological age alone may not be correct. And well-selected elderly patient with minimal comorbidity, so it's quite important to do a very nice selection, may be candidate for allogeneic stem cell transplantation. So it is a difficult choice, but we have to think about this. Why we use DIPSS re-stratification for the selection of patients for stem cell transplant? Together with Nicholas Kruger, we did this study, and this study compared from the time of diagnosis, patients who receive stem cell transplant versus those who did not. And we found that the stem cell transplant is an advantage for patients with risk intermediate 2 and high, without any doubt. It is dangerous for patients at low risk. And there is no difference in patient intermediate 1. This is, remember, we published this 6 years ago. We have not so huge information about mutation, but this is a potpourri of different mutations. So this is the area where we need to have more mutation, more information to select better patients. And more recently, the Center for International Blood and Marrow Transplant Research did the same study. They enrolled many patients. Some received stem cell transplant, others did not. And they found similar results for intermediate 2 and high risk. They found also differences and advantage for those who received stem cell transplant, but only after a long period of time. You know, this is a sort of plateau, but this needs more than 6, 7, 8 years of observation. Concerning low-risk patients with a proper statistical analysis, the P is significant, but the difference you can see, the advantage you can see with stem cell transplant is more than after more than 10 years for stem cell transplant. This is the MTSS. This is just a more deep detail, but we have already discussed this. However, this is a nice model. I use it. But for instance, the Spanish collaborator very recently found that this is not able. So they were not able to confirm the validity of the MTSS. And they use the MTSS also only for subgroup patient into 2 categories. So low risk, intermediate 1, intermediate 2, and high risk. And they found that, for instance, the sorrow comorbidity, the donor and the are negative predictors, while post-transplant cyclophosphamide was a positive predictor. So Spanish developed a different prognostic model. And I think that overall, the number of patients who receive stem cell transplant are low in general. So it's a very heterogeneous patients. So it's not easy to have a unique model to predict survival. What about other parameters? For instance, post-transplant determinants of outcome. Very nice. This is a data from coordinated by Spanish collaborator of the ABNT. They found that the graft failure impact on the overall survival, as well as acute GVHD. It is very significant difference in terms of survival in those patients who had acute GVHD versus those who have not. How can we prepare a patient to stem cell transplant? Today, of course, all patients more or less receive ruxolitinib. But if a patient receives ruxolitinib and obtain a clinical improvement at the time of stem cell transplant, the overall survival is quite good. The non-relapse mortality is quite good. And the relapse in general is quite good. That is clearly significant difference, at least for overall survival, respect to those who are in blast phase or different conditions at the time of stem cell transplant. So prepare a patient with ruxolitinib, reduce the spleen, improve symptomatology, obtain an improvement of some parameters may be helpful for the patient. And this study has been confirmed by the BMT on a very large number of patients who receive ruxo-suppressed stem cell transplant. What about splenectomy? This is a big matter of discussion among transplanters. And this is the last publication performed on the basis of the EBNT registry. 1,195 patients with myelofibrosis receiving stem cell transplant. Splenectomy did earlier, before stem cell transplant in 202, 16.9% of the patients. The number of patients who received splenectomy decreased due probably to some information about splenectomy pre-MF, due probably to the fear to have complications, due probably to the ability of ruxolitinib to reduce the spleen at the time of stem cell transplant. However, splenectomy was associated with less non-relapse mortality, but with an increased risk of relapse and no significant impact on overall survival. So I think that this can be considered a statement on splenectomy pre-stem cell transplant myelofibrosis. However, they did also a sort of sub-analysis evaluating splenectomy versus specific spleen size. And they found that patients who had a spleen length more than 50 centimeters from the left costal margin, when compared to those who received splenectomy, have a worse survival. So probably in the niche of patients with a huge splenomegaly, it's probably better to do splenectomy. But the overall message of the study is this one: no advantage in terms of survival in patients who receive splenectomy. Another important point: what about the donor? Has an impact the alternative donors? This is an analysis done by Bregante in Italy. She studied the effect on survival of the donor, sibling donor versus alternate donor, in the year 2000 versus 2010 and 2011 to 2014. While at the beginning, there is a significant difference in terms of survival among those who those with sibling donor versus alternative donor. In the last year, there is no significant difference in terms of survival. So we can use the better donor we have at the time of the cell transplant if we think the stem cell transplant is indicated for this patient. Another point is myeloablative regimen versus reduced intensity conditioning regimens. This is a study done by the Chronic Myeloproliferation Working Party of the BMT. It is recent. Compare a huge number of patients who receive myeloablative versus a huge number who receive RIC transplant. You can see here that there is no difference in terms of survival among patients who receive MAC versus RIC. There is no difference, just a borderline trend of the incidence of relapse between those who receive reduced conditioning versus myeloablative. And finally, there is no difference in the incidence of non-relapse mortality among these two cohorts, these two treatments. So basically, in younger, fitter individuals who tolerate MAC, I think that we have information that these patients still continue to be considered for the MAC platform. While, and this is of course another important information, it is that if we have older patients fit, we can consider RIC regimen because the advantage on survival has been very well demonstrated. But again, we need to select patients very carefully. Another recent information is on day 30 full donor chimerism after stem cell transplant. You can see that, of course, having a full donor chimerism impact on the cumulative incidence of relapse. And in this cohort of patients, some patients receive one single alkylator either thiotepa, busulfan, or melphalan. And another cohort, this is not a randomized study, this is a retrospective analysis. And the second cohort received 2 alkylating agents, so thiotepa, busulfan, plus fludarabine. And you can see that in this cohort, so thiotepa, busulfan, fludarabine, authors reported a higher rate of full donor chimerism. And also in terms of disease-free survival, receiving thiotepa, busulfan, and fludarabine is better than receive only one single alkylating, either busulfan or melphalan or thiotepa. So this provides a suggestion for the conditioning regimen. In Italy, we did this study. Francesca Patriarca led this analysis. We randomized patients to receive fludara busulfan versus fludara thiotepa as conditioning regimen for stem cell transplant. And we did not observe difference in terms of non-relapse mortality, in terms of progression-free survival, and also in terms of overall survival, even if it seems that fludara thiotepa seems better. Another study, prospective study, phase 2, compare low dose of busulfan plus fludarabine versus higher dose of busulfan plus fludarabine, or tailored dose of busulfan on the basis of the PK. And authors find that the relapse was higher in patients who received low dose busulfan versus those who receive higher dose of busulfan. And this is, of course, important. And the 3-year event-free survival rate was significantly better in the high-dose group, 58%, than in the low-dose group. Even if at the end, the 3-year probability of overall survival was similar. And lastly, I want to discuss with you how can we manage a patient after stem cell transplant, what is relevant. We know that the chimerism is important, but also assessing the mutational status of the patient is relevant. So this is a patient with more than 140 cases enrolled. Some of these, the majority, had the JAK2 mutation, some MPL mutation, and several have CALR mutations. And so in the cases of MRD positivity and MRD negativity, you can see an interesting differences in terms of incidence of relapse. So the relapse is higher in those patients who are MRD positive at day 100. And also the disease-free survival is better in those patients who are MRD negative at day 180. So probably we had to study to assess the MRD status and chimerism in tandem to determine whether use DLI or whether DLI has been required for this patient. So these are my conclusions. The decision on the treatment of myelofibrosis patient need to start from a proper risk stratification of the patient. I think that we can use IPS or DIPS if we have not NGS available, NGS technique available at our institution. And if we have NGS available, MIP70 can probably stratify better patient with an age below 70. And this is for primary myelofibrosis. For secondary myelofibrosis, so post-PV and post-AT myelofibrosis, I suggest to use MySEC-PM because MySEC-PM is the only one that has been developed in patients with post-PV and post-AT myelofibrosis. Ruxolitinib is the standard treatment for patients with myelofibrosis in most countries. And it is effective to reduce the spleen, to improve symptomatology, and lastly, to improve overall survival of patients with myelofibrosis. Side effect, anemia, thrombocytopenia, and infections, all manageable. Fedratinib is approved by FDA in US as first line and after ruxolitinib failure. We have now under investigation the drug in terms of safety in 2 big studies, mainly done in US or in Europe. Luspatercept seems promising in patients with anemia, either on ruxo or without ruxo. And we are doing now a study, the independent study, that will give us the final answer of the efficacy of luspatercept in myelofibrosis. And what is good for me is that other target therapy are under investigation as single agent and using ruxo as a backbone. Because I personally think that more target will allow us to improve results in our patients, to have more spleen reduction, less anemia, more alteration, more variation of the bone marrow, more reduction of the bone marrow fibrosis, and lasting impact on overall survival. But finally, stem cell transplant is still central. Also in this JAK inhibitor here is still central myelofibrosis. But the most difficult things is the selection of the patients. So we have to use everything we can do to stratify better the patient, just to have lesser mortality in this very important but very risky procedure. So I finished and I thank you for your attention.
Thank you, Prof. Passamonti, for this excellent review on myelofibrosis, especially on the transplant. So I will present 2 cases, and I'd like to take your opinion on these 2 cases. So. I'm trying to share. Okay. This slide is there, Ahmed?
Yeah, I see.
Okay. So case 1, this is a 48 years old Saudi female patient. She has unremarkable past medical history. She was incidentally found to have splenomegaly after she was examined by her daughter, who is a 4th-year medical student. She's totally asymptomatic, and she was found to have spleen of 17 centimeter. Then her daughter took her for CBC, and she was found to have a white count of 82, mostly are neutrophils. With the 92% of her white counts are neutrophils. She has some basophils. Her hemoglobin was 11.8, and her platelets were 166. So considering that she has a splenomegaly and neutrophilia, she was referred to us as a possible of CNL or chronic neutrophilic leukemia. Her peripheral blood film showed prominent neutrophilia, mild basophilia, left shift. There was no leukoerythroplastic pictures, and there was no circulating blood. So she had a bone marrow studies which showed a hypercellular marrow with cellularity more than 90%, with active erythropoiesis and granulopoiesis, no dysplasia. But her marrow was remarkable for increased megakaryocytes with polymorphism and atypia, and some of the megakaryocytes were arranged in a loose clusters. And her reticulin fibers were +1, and collagen stain was negative. She has normal karyotype by cytogenetic. Her BCR-APL was negative. Her LDH was normal, and rest of routine blood work was within normal. So initially, because as I mentioned, she was referred as query chronic neutrophilic leukemia, so we sent her myeloid, NGS myeloid panel, and she was found to have a JAK2 positive, but her CSF 3R was negative because we're thinking of CNL. And she has no other abnormal mutations, including MPL, carotecholine, ACXL, and other mutations. So just she had JAK2 positive mutation. So she was signed out as most likely pre-fibrotic myelofibrosis, considering she had grade 1 fibrosis, megakaryocytes, atypia, JAK2 mutation, and absence of CSF-PR. Using risk stratification, she was found to have intermediate 1 by GIPSS for absence of carotecholine, and by MIPSS 70 plus variant 2, she was low risk. So we would like to hear from you, Prof. Passamonti, about, on this case, about diagnosis challenges for this case and pre-fibrotic myelofibrosis cases, treatment recommendations, especially for younger patients, and when to consider transplant and how to monitor these patients. So
I think, Hamad, that this is a very nice description of a case, very well studied. Congratulations. And the point is, this is a patient relatively young, 48, female, with a huge spleen, 17 centimeters from the left costal margin, with leukocytosis. So I think that is a low-risk patient, but I personally, in a patient like this, we can use hydroxyurea or ruxolitinib. I expected that ruxolitinib will be much more effective than hydroxyurea in reduce the spleen volume. So probably, my choice will be on ruxo. How can we follow this patient, which is the follow-up? Basically, this is a pre-fibrotic MF. So the course of the disease will be probably much better than the course of the disease of a patient with myelofibrosis, full fibrotic myelofibrosis. So I think that if you start with ruxo or Idria, what is your choice? I don't know. It's quite important to check the trend of the spleen reduction and to maintain the smallest possible the spleen size, and to continue. In a patient like this, even if this is a young patient, but the disease is a benign disease because it is a pre-fibrotic MF. So in this situation, I generally do not suggest stem cell transplant, but you have time, you can follow this patient and see what happens, because she is very young, so 48, and you can potentially do stem cell transplant till the age of 70 or probably 71, 72, 73. Which was your decision on this patient?
So we started her on, because she has high count, and actually we started her on hydroxyurea, and she was started before she came to us because of the high count and possibility of CNL. But she responded to the hydroxyurea in the form of lowering her count and improving her spleen. So now she is with me for the last maybe 4 or 5 months, and she's on hydroxyurea and aspirin.
How long was the treatment with hydroxyurea? Month or years?
It's about 4 months now.
4 months, just at the beginning. Okay.
Yeah.
So I think that I agree with your choice, and you have probably to monitor this patient. What I expected on the basis of my practice that this response you have obtained is quite brilliant, but potentially you will lose the response in I don't know 1-2 years or something like this. The expectation of life of a patient with pre-fibrotic MS is quite longer, but probably you will have the need to a second-line treatment. So if you look at the ELN guidelines, we say start hydroxyurea, then at the failure of hydroxyurea, start with ruxolitinib. So I hope that you will manage very well with Idria, but I fear that in 1-2 years in general, the response will be lost.
Now, for follow-up and monitoring, will you depend mostly on the clinical findings, or how often you will?
Absolutely, absolutely. I follow with CBC count and palpation of the spleen, nothing else. If you have sign of progression, for instance, anemia, even if you reduce hydroxyurea then I check bone marrow biopsy. But if I have no sign of progression, so no symptomatology, no regrowth of the spleen, no anemia, no thrombocytopenia, no blast in the peripheral blood, I usually do not check bone marrow and do not check JAK2 mutation or other additional mutation. So,
Good. Okay, so
is this your practice, or do you manage patient?
we do mostly on clinical, as you mentioned.
Yeah.
On we follow up and do workup mostly based on clinical progression.
Yeah.
Okay, so I move to the second case. This is a 67 years old Saudi male patient. He was diagnosed in 2004 with polycythemia vera. At that time, he presented with erythrocytosis, splenomegaly, and his marrow was consistent with polycythemia vera and no fibrosis. He was found to have high platelets and white count, so he was started on venesection, aspirin, and hydroxyurea. And in 2008, he had his JAK2, it was available by that time in Saudi Arabia. So he came to be JAK2 positive. In 2010, he started to have a progressive splenomegaly with constitutional symptoms, and his bone marrow biopsy consistent with the post-polycythemia vera myelofibrosis with the +2 reticulin fibers. So during that time, we didn't have ruxolitinib, and he had a match SIB, and he was referred to a transplant center, but he was rejected because of his age. It was a late 50s, and as a being secondary myelofibrosis. So he continued on supportive treatment. In 2012, he was started on ruxolitinib, and actually he was one of the patients included in the JUMP trial, and he achieved excellent response to ruxolitinib in the form of splenomegaly and splenomegaly-related symptoms. In late and this response continued for about 6 to 7 years. And in late 2019, he started to lose the response to ruxolitinib with, again, progressive splenomegaly and progressive symptoms. His NGS done at this time and showed ACXL1 mutation, and his MIPSS was high, 6 points, and I just calculated his MySic, it was intermediate 2. And he had trials of hydroxyurea plus ruxolitinib, adding hydroxyurea to ruxolitinib, but no response. And then we used ruxolitinib with big interferon, but again, he did not respond to that, and he continued to have the symptoms. We don't have fedratinib yet in Saudi Arabia, but we are requesting for him as a non-formulary, but still not available. So you mentioned during your presentation treatment post ruxolitinib failure, but if there is anything you would like to add to this case.
So this is I think the real unmet medical need in our patients. So it is not easy, because at the time he is 67 plus 16, so 70, 83, correct?
No, he's 67 right now.
67 right now. So okay,
Yeah.
sorry. So 67, no chance for stem cell transplant. And I think that if the probably better choice is to do a clinical trial. If you have no clinical trial, I think that one very old drug that is effective is busulfan alone. So busulfan is an alkylator, and I use this as a last chance for some patient obtaining good response in the spleen and control in leukocyte count. An alternative is some sort of chemotherapy. So if this patient is has problem with splenomegaly, some cases use either rubicin or aracetin chemotherapy intravenous, to reduce this massive splenomegaly. And in some cases, it is effective. Because, of course, you have used Ruxo, you have used Ruxo plus hydroxyurea, PEG interferon in general. If the patient has a big spleen, is ineffective. So this is what I can suggest to you. So basically, I think that busulfan might be a good option. What was your decision?
If we have fedratinib, you would.
Fedratinib would be excellent. Because fedratinib, I used, you know, in Italy we have not, as in Europe, we have not yet approved fedratinib, but I used fedratinib in the Jakarta 2 study, and many years ago, and I remember very excellent reduction of the spleen symptomatology in patients who failed ruxolitinib. So my feeling with fedratinib is that this is a nice drug, very effective, and you can use, and this is very effective in patients with a platelet count between 50,000 to 100,000. So if you have the possibility, fedratinib is the perfect choice.
Okay, so I see we have some questions. So question from Dr. Ziad Shaybani. Would you agree if spleen is 20 to 20 centimeters pre-transplant will benefit from splenectomy to decrease the risk of graft failure post-transplant?
Yeah, the question is, which is the levels of splenomegaly, sorry?
No, he mentioned just between 20 and 22 centimeters.
Okay.
He mentioned.
If you have a huge spleen, so 22, 25 centimeter by palpation, it means a very huge spleen, and there is a global indication to do stem cell transplant. Because if you look at the clinical study, in those studies where there is a demonstration that splenectomy is not effective on finally on survival, the median size of the spleen was relatively small. So if you have a huge spleen like that, I think the splenectomy is mandatory. The point is that the splenectomy per se is very dangerous, harmful in patients with a so huge spleen. So you had to contact the best surgeon you have in your hospital.
Okay, there is another question that, again, a case scenario, 43-year-old with male with primary myelofibrosis, and he has also a dural venous thrombosis 2 years ago, JAK2 positive splenomegaly 17 centimeters, thrombocytosis, but it seems no symptoms, and DIPSS is low, and nothing mentioned about other mutations. So the question, do you wait for him to start Jakavi?
Oh, this is a patient with the splenomegaly was by palpation 17 centimeter.
Yeah.
Oh, this is a patient with a very myeloproliferative disease, so leukocytosis, erythrocytosis, thrombocytosis, and huge splenomegaly. It seems to have a phenotype that is more a PV phenotype more than PMF phenotype, you know? And for instance, if you confirm that the case is a primary myelofibrosis and not a PV, I think that you can start either with Ruxo or hydroxyurea. But just seeing the CBC count, it seems more a patient with polycythemia vera. Because the hemoglobin is 16.5, you know?
The bone marrow morphology is crucial.
Okay, so in this case, I think that is so myeloproliferative that you have the indication for or Ruxo or hydroxyurea. In my practice, as this is a DIPS low, I use hydroxyurea. Mm-hmm. For one important reason, in Italy, there is no indication to use ruxolitinib for low-risk patients. And you know that the evidence for the literature is very low for low-risk patients. So I use, in these cases, low-risk myelofibrosis, I use hydroxyurea. If hydroxyurea will fail, I will use Ruxo as second line. I don't know, in the kingdom, Ruxo is allowed in low-risk patients with myelofibrosis?
Actually, it's we use it mostly in the intermediate 1 to
As in Italy, okay.
yeah. Okay, there is a question about busulfan you mentioned for the late stage. Question is about how frequently and how much you will use.
No, I use busulfan in some cases, so anecdotally. What is important, as we know that busulfan is an alkylator, and so there is the possibility of cytopenia. In some cases, cytopenia is severe and very long-lasting. So I usually start with 4 milligram per day, checking CBC count every 2 weeks. And I reduce the dose as soon as CBC count start reducing significantly.
The only point, I'm not sure if we still have oral busulfan or no.
No, oral busulfan. Yeah, oral busulfan.
Yeah, but I mean the availability now, because we are not using it anymore in the conditioning. Okay, there is another question. Is any rule for splenic irradiation? And maybe I will add to that, when can you consider splenic irradiation and when to avoid splenic irradiation?
I think that splenic irradiation is very rarely used for the time being. And the problem is that you can have a severe cytopenia, very severe cytopenia. So the rate of mortality after spleen irradiation is high for infection. I remember some terrible cytopenia, leukopenia with severe infection similar to those of acute myeloid leukemia. And so I do not use it I do not use it. You know that in some cases, for instance, before stem cell transplant, some doctors want to use radiation for a part of the spleen just to reduce splenomegaly before stem cell transplant. This is a practice for some doctors.
Okay, another question, case scenario, 34-year female, just referred with a post-ET myelofibrosis. And Dr. Musab, the one who submitted the question, he did not see her yet and did not calculate my sick yet score, but he mentioned if she has a SIB donor available, would you suggest early transplant for this young lady with post-ET myelofibrosis?
You know that really it's not easy to discuss this case without the information on the score. If this is a severe condition, so a MySEC PM intermediate 2 or high, you have to consider this. If the score is low risk or intermediate 1, I advise to postpone stem cell transplant because this is a very young lady. You know that the disease in young person is more slow than in older one. So I suggest if the score is low risk intermediate 1, do not use stem cell transplant so early. You can wait. You can see what happened in the disease. So
now I have a question for the conditioning or the transplant for myelofibrosis. Where the benefit comes, is it from the conditioning, the intensity, or from the GVL effect?
This is, of course, so can you repeat the question?
I mean for using the transplant for myelofibrosis.
Yeah.
Do we get the benefit from the intensity of
the
chemotherapy or from the GVL effect?
Yeah, of course, the GVL effect has been demonstrated in myelofibrosis. And the final outcome of a stem cell transplant in myelofibrosis is very difficult to say what is the most important predictor or facilitator for the final outcome. I think that the GVL is not so important as in AML or other diseases. This is the experience. And what is important, I think, is to use fully ablative if the person is young, RIC with a busulfan, thiotepa, and Fludara. That is probably the most important use RIC regimen to monitor the follow-up of this patient, not only with clinical parameter, but also with, for instance, the minimal residual disease assessment and so on. So it is a real combination of many things. That's a plan, yeah. But the selection of the patients, so doctor who send you patient with this indication, you have to select very carefully this patient, because the selection is the most important key point.
Okay, I think by this time is almost on. So I would like to thank Prof. Passamonti for this nice lecture. And again, I would like to thank the attendants for their time and Novartis for sponsoring this meeting. And hope to see you next week on another SSBMT webinar, which will be on how I treat nodular lymphocyte predominant Hodgkin lymphoma by Dr. Graham Collins. And by this, we come to the end. Thanks to all. Thank you.
Thank you. Thank you for the invitation.
Thank you, Francisco.
Thank you,
very
Prof.
nice.
Thank you. Thank you very much. Bye-bye.
Thank
Have
you.
a nice evening.
Bye.